Hello everyone, I'm Ambrus Szemere, and my PhD topic is the relationship between sedation, sleep, and post-intensive care unit outcomes in critically ill children. I currently work at the Department of Anesthesiology and Intensive Therapy and at the second Department of Pediatrics at Semmelweis University. I'd like to improve pediatric intensive care with protocolized strategies, and my mission is to contribute to the creation and implementation of clinical guidelines in pediatric critical care. To achieve my mission, I have more specific topics. Currently, I'm working on these 3 projects. The first one is the effectiveness and safety of protocolized sedation in the pediatric intensive care unit, which is a meta-analysis. And we are interested in this topic because sedation practice needs to be improved. About half of ICU-admitted children are ineffectively sedated, which is a major challenge because inadequate sedation leads to adverse events, which prolongs the duration of ventilation, which leads to further adverse events, increases the overall complication rate and the risk of mortality. But protocolized sedation strategies has shown to be effective in adult studies, so we aim to compare the effectiveness and safety of protocolized sedation in the pediatric population. We define the strategy as protocolized sedation if the level of sedation was assessed and modified based on a predefined algorithm, like a protocol, and our primary outcome was the duration of invasive mechanical ventilation, and we're also interested in any type of ventilation or sedation associated adverse event, the length of stay and mortality. We hypothesized that protocolized sedation is superior. We've conducted a systematic search in these 5 databases with this search key in October, and we've managed to reduce our 5,000 results to 21 eligible articles. Primarily, we were interested in the duration of ventilation. We compared protocolized sedation to usual care, and we found a high heterogeneity of 65%, mainly caused by the differences in the clinical settings and environment and the different baseline characteristics of the included population. Also, we found a mean difference of 12.5 hours. Usually, a half-day shorter duration of ventilation could be clinically significant. However, our result was not statistically significant. We also reported a high risk of bias in several non-randomized articles, but we're also interested in the length of ICU stay because it is strongly interrelated with the duration of ventilation. We found a similar level of heterogeneity here caused by the similar reasons in the same articles, and also we found a similar effect size. The mean ICU stay was a half-day shorter in the protocolized sedation group. The result was not statistically significant. We also reported a high risk of bias in many articles here. We are also interested in the length of hospital stay because ICU discharge policies can differ between hospitals, and here we found an even higher level of heterogeneity of 86%, mainly caused by that we've calculated a mean and standard deviation from skewed, probably non-normally distributed data, and we've also observed a significant level of heterogeneity in the baseline characteristics between the populations. Here also we reported a mean difference of more than a day, so the length of hospital stay was more than a day shorter in the protocolized sedation group, but our result was not statistically significant. We're also interested in, yes, we've seen a high risk of bias in 2 articles, but we're also interested in the safety of protocolized sedation. And we found that protocolized sedation does not significantly increase the incidence of withdrawal syndrome, unplanned extubations, extubation failure, and 28-day mortality in this population. So we can say that we've conducted the first meta-analysis that investigates protocolized sedation in the pediatric intensive care unit. We've had a sufficient number of articles with more than 14,000 patients, and our latest included article was published in 2021. However, we pooled cluster RCTs, pilot RCTs, and non-randomized studies together, and we've calculated mean and standard deviation in skewed, probably non-normally distributed data. Also, the high heterogeneity and the serious risk of bias limits are results. So in conclusion, the clinical benefits of protocolized sedation are not supported, and we've reported the conflicting results regarding some outcomes, and also the observed heterogeneity limits the results for several outcomes. So we can say that protocolized sedation management is a safe sedation minimization strategy, but its clinical benefits are still questionable. And also validated sedation assessment instruments should be used in all critical care settings, and the staff needs to be trained to use it. So we need further research to evaluate the effect of protocolized sedation strategies in various clinical environments. My next project is the disruption of circadian rhythm in the pediatric intensive care unit measured with actigraphy and its relationship with psychological outcomes. We are interested in this topic because there are several factors that affect sleep in a pediatric intensive care unit, which is a major challenge for us because the integrity of sleep-wake cycle is critical in developing an adequate immunologic response and also has a role in cognitive development, and its disruption could compromise the physical and psychological recovery. So we aim to measure the risk factors, the development and the progression, and the psychological impact of circadian cycle disruption. Here you can see my question and PICO. We are primarily interested in the objective of measurement of sleep with actigraphy and also its psychological impact. We hypothesized that ICU admission, sedation, and invasive mechanical ventilation has several impact of sleep, and it has long-term consequences. We plan to determine the modifiable risk factors and the psychological impact of sleep disruption. We enroll children from an ICU and a pediatric ward. We'll measure sleep disruption with actigraphy, and then in the follow-up phase, we measure psychological disorders, sleep disorders, and quality of life with questionnaires. In summary, you can see all my projects here. And to conclude this presentation, I use this quote for you, which I think best describes critical illness and sedation. Do not go gentle into that good night. Rage against the dying of the light. Thank you for your attention, and if you have any question, please feel free to ask.
I would like to have a question about your first topic, that did you consider in your assessment what the protocols are consisting of regarding to the sedatives they used? Newer agents probably have better outcomes than older ones.
Yes, thank you for the question. The problem with the universal protocol that it needs to be adapted to the critical care settings. So it's really different between different type of intensive care units, different countries, different practice, because the staff needs to be trained to use a sedation strategy. So we couldn't just wanted to, investigate one specific sedative and its effects, because many other meta-analysis and RCT is already done that we are interested in. If it's the sedation strategy and the assessment and the modification of sedation is protocolized, is it effective and safe or not concentrated on a specific agent.
I saw in your limitation you said heterogeneity.
Yeah.
What I believe, there is no good or bad heterogeneity if you know the reason behind that. So do you have any explanation?
First of all, we pull together RCTs and non-randomized studies, and usually cohort studies especially with a retrospective group with different characteristics of the included patients, are a cause of high level of heterogeneity. And also I put together cardiac intensive care units, postoperative intensive care units, and medical intensive care units. So the duration of ventilation and the mean ICU stay are greatly differed between them.
Are there feasible subgroup analysis for sedation protocols?
We can conduct a subgroup analysis, especially with different study designs or ICU settings, but the effect size was very similar, so we are not sure if it's worth it.
So the protocols are quite different from each other?
Yeah, the protocols were different, but usually the level of sedation was based on an SBS or Comfort B score, and the reason for different protocols was only the primary sedative agent and the doses of different sedatives and analgesics. But as you can see, the effect size was very similar.
I suggest you to perform a subgroup analysis from non-randomized and or quasi-randomized and randomized controlled trial that maybe decrease the heterogeneity. Thank you.
Thank you.